All right, Dr. Wallen, thank you for joining us today. I really appreciate you, sacrificing some of your valuable time to, teach us about your field.
No, it's my pleasure.
So tell us a little bit about yourself, like your hometown, undergrad school, and major, stuff like that, and then also where you went to med school.
Sure. So I was born and raised in Erie, Pennsylvania, the very northwest corner of Pennsylvania. I did my undergraduate studies at the University of Pennsylvania down in Philadelphia. When I finished up as an undergrad, I spent 2 years working in a cardiac surgery lab, managing clinical trials at the University of Pennsylvania. After that, I returned back to my hometown, back to Erie, and I went to LECOM, the Erie campus, obviously.
Yeah.
Spent a few years there doing my preclinical years, did my clinical years down sort of in southeastern Pennsylvania, in and around the Philadelphia region. I then interned at Penn State Hershey Medical Center, and then I did my residency at Mercy Catholic Medical Center, which is in Philadelphia. And then after residency, I moved south down to Florida, where I am now at the University of Florida as a thoracic and cardiovascular surgery fellow.
Awesome. That sounds really cool. Although I don't know, Erie, Pennsylvania is probably the one area. I grew up near Syracuse, and we always used to joke that Syracuse is the snowiest city in America, but Erie is probably the snowiest town in America. So
Yeah,
I don't know
we
about that.
certainly deal with our share of snow. I mean, luckily, the house I grew up in, my parents' house, was only about a mile from the medical school front door. So even if driving was out of the question, you could still theoretically make it. So.
Yeah, that's you can at least walk uphill both ways in the snow or whatever the old saying is. So my next question is why this field of surgery, and it sounds like you knew a little bit about that at least before you even started med school because you were working in a cardiac lab. So why cardiothoracic surgery?
Yeah, I mean, it initially started out as sort of a good research-based job, right out of undergrad. That's something that a 21-year-old kid can wrap their mind around. And like a lot of medical students and a lot of sort of young people in the field, the big driving factors behind specialty choice tend to be early exposure and mentorship. And I was fortunate to have both of those things. When I was working down at Penn, we did a lot of great research. We worked on a lot of sort of cutting edge device technology. I got to see a lot of very interesting cases. And probably more importantly than that, I had a lot of really good mentors. I had some very inspirational people that I worked with who worked really hard and did a great job and took an interest sort of in me and making sure that, I was getting where I wanted to go and things like that. And those things put together really kind of lit the fire for the field. I mean, I'd always wanted to be a surgeon most of my life. I think I was pretty sure I wanted to be a doctor, wanted to be a surgeon. And then I found cardiac sort of through work, and then moving through the education process and training and all that sort of stuff. Nothing, really sort of excited me the same way that cardiac surgery does. I think people pick specialties for two basic reasons. One is you really like the patients you're taking care of. Some people love taking care of kids, so they become pediatricians. Some people love taking care of old people, so they become geriatricians. Some people love taking care of women, so they do OBGYN and women's health, or whatever the case may be. And other people pick a specialty based on pathology. And that's sort of what clicked for me. When I was in your guys' shoes in the preclinical years, it sort of made sense to talk about flow and pressure and gradient. And my brain just sort of could wrap itself around that better than it could interleukins and cytokines and all that sort of stuff. So I just kind of gravitated towards the field and stuck with it kind of the whole way through general surgery training. I think there are a lot of other reasons to become a cardiac surgeon. I think that, one, every case you do is a big case. There's really not a lot of minor procedures that we do. And then you get to deal with big questions. I mean, a lot of what I did in general surgery and what other, fields do is they make people feel better. And that's great. There's nothing wrong with that, but a lot of times when we talk to patients, we're talking about survival, mortality, 5, 7, 10-year outcomes. And you make big decisions and you get to help patients through those big decisions. And I've always really enjoyed that. And then on top of that, we have a big patient population. Cardiovascular disease is certainly very prevalent in our society. It's not going away anytime soon. And we get to play with a lot of really cool toys. We have a lot of great technology in our field. It's constantly growing. It's constantly evolving. So you get to treat, something that, if you want to think of as simply as aortic valve disease, it used to be sort of a one-stop shop, is now got a multitude of different treatment algorithms that you can work through with minimally invasive techniques, open techniques, transcatheter techniques. So I think the ability to sort of focus my practice on a narrow pathology, but still have this wide breadth of skills and tools that I get to use was very attractive to me, sort of coming out of general surgery.
Well, you've sold me. I'm in. No, I'm kidding. I've got a few years before I have to decide. Although it is very fascinating to me and something I'm definitely interested in. So yeah, thanks for sharing that. That's a really complete answer, and I really like that. And then my next question is, why did you pick the residency program you did? And this, obviously, you actually had multiple, so maybe you could comment on that. And then, and what were your criteria that you were looking for when you were, like when you were at an interview or maybe doing an audition rotation, like what you were thinking about, like, oh, this is a bad sign or this is a good sign?
Sure. I mean, I think going back to sort of my earlier answer, mentorship has played a big role in what I've done throughout my training. And when I was a PGY3 sort of mid-level resident on the cardiac surgery service at Penn, my fellow was a guy named George Arnatakis, Dr. Arnatakis, who is now my attending here at the University of Florida. So he finished up at Penn and came down to Florida, became an attending, started working through the academic ladder down here, has developed a really busy practice. And I stayed in contact with him, and we shared mentors back in Philadelphia. And so obviously having sort of that person on the ground that can give you insights was really helpful. And then my criteria, were a place where we were going to be busy. Sort of one of the, subtle differences between residency and fellowship is, in fellowship, the end of that very long tunnel is clearly in view, right? And so you want to be at a place where you're going to get really good experience, do a high volume of cases, and really wrap your hands around things that you're going to be treating for a long time in your career. So I wanted to be at a busy place. I wanted to be at a little bit of a bigger place that could offer the breadth of our specialty, including heart-lung transplantation, transcatheter techniques, and then on the thoracic side of things, robotic surgery, ECMO, all those sort of modalities. I wanted to at least have some experience in. And then on top of that, within sort of your particular niche of cardiac or thoracic surgery, there's, certain things that certain places do, I don't want to say better, but that's sort of their focus, right? Some places are really advanced heart failure transplant places. Some places are really big into minimally invasive. One of the things that they do really well here at UF, among, other things, obviously, that they do really well, is do a lot of complex aortic work and a lot of transcatheter work, and that has been an interest of mine for a long time. So the opportunity to be at a place where I could see the gamut, get involved in everything, but also sort of get advanced training and sort of the niche within the specialty that I really enjoy was great. And then on top of that, it's warm here 12 months out of the year. You don't have to shovel the humidity. There's a lot of other nice things about Gainesville and about UF. And I've been, as you will soon experience, some of it is a crapshoot. It's a match process. You don't know where you're going to end up. You're taking a lot of stuff on faith, but I've gone back to sort of those things that were important to me early, and I've got really good mentors here. There's a lot of different people that I can call with questions and concerns, and we do a lot of cases, and it's been a really good experience. So I'm definitely happy with my choice. I think, to sort of more succinctly say it, I wanted to be at a busy place that offered the gamut in terms of our specialty, but had to focus on sort of complex aortic and transcatheter therapies. And that's sort of what led me down to UF.
That's awesome. Yeah, and I really appreciate the sun thing. I lived in Florida. I lived in Tampa for a little while when I was in the military, and I miss it because right now it's November in Michigan. So, I love Michigan State, but November and December and January, not the best. So I appreciate that. I also really like the transcatheter stuff. I think that's really cool. And I think going forward, a lot more stuff is going to be transcatheter and stuff like that. So I like that you're at a program that's good for that. It's pretty interesting to me. So personally, anyway, that's pretty cool. So my next question is like the worst question to ever ask, but it's a popular question, so I'm going to ask it anyway, which is, what a typical day is like. Obviously, it's surgery. There is no typical day. So, maybe a couple of typical days or even just, what happened yesterday is fine, whatever you think.
Well, I think I'll sort of roll out all the possibilities, right?
Great.
in our program and sort of in our specialty in general, you usually spend about a half a day to a full day in clinic every week, seeing your patients, evaluating people, seeing new consults, checking on your post-ops, things like that. And that's sort of similar to a lot of other specialties. So I won't go too much into detail, but, I tend to come in the morning and gather all the necessary data on the patients that I'm helping to take care of and the patients that I'm sort of responsible for. Go around and see everybody, make my own rounds before I head down to our pre-op area. I meet my patient again, hopefully, for who we're going to be taking care of that day in the OR, answer any last minute questions, talk to their family, that sort of stuff. Typically after that, I make a stop off and grab my coffee and then it used to be to a conference room, but now it's more this scenario where we have some type of educational activity in the morning for about an hour, usually early in the morning, where we do board prep or case management, or we have a journal club or something like that. We do that about 3 or 4 days a week. After that, we sort of have formal, big rounds with the ICU team. All of our extenders participate, the ICU team participates, respiratory therapy, case management, all that kind of stuff. We come together, talk about all our patients in the unit. And then from there, we go down to the operating room. And I think that's maybe one area that's a little different than other surgical specialties. Our cases are, rightfully so, a little complicated and a little complex. So there's a lot of setup. There's a lot of takedown. A typical case runs somewhere, in the nature of 5 to 7 to 8 or longer hours. So it's kind of an all-day affair. And normally you're going to do 1 or 2, sometimes 3 cases in a day, but a lot of times time doesn't allow for more than that. After our cases, usually run up to the ICU, check on everybody one more time, do anything like this that I need to do, or catch up on my emails, paperwork, all that kind of stuff, and then head out for the night if you're not on call. We also participate in the transplant program here. So the phone can go off sometimes and they'll ask you to fly this, there, or the other place to help procure organs for transplantation. We, here at UF, we get trained on that in our first year. And then in the advanced years, we do that independently. So you serve as the attending on those transplant runs. We obviously have a busy sort of emergent business as well, because those organs go into somebody, right? And then on top of that, we do aortic dissections and sort of other things in the middle of the night. So that stuff can also arise as well. And then, we take weekend call intermittently amongst the 3 fellows here. We have a backup call system, so usually you're somewhat involved one way or another. I think deviations from that are clinic days or days that we're going to spend doing transcatheter cases. You might do more cases, 3 or 4 or whatever, over the course of a given day. And then occasionally we'll have sort of, we have interview days for the fellowship and the residency, and that stuff comes up every now and then, and there are educational retreats and things of that nature. But one of the sort of desirable things to me about the specialty and about the program here is you spend majority of your time in the operating room. So, if let's say I get in at 6, I'm in the OR hopefully by like 8:45, and then I come out at 4 or 5 o'clock, and then spend a couple hours wrapping things up and then head home. So most of us surgeons in general, and especially heart surgeons, we like being in the OR, and so it's a nice specialty because you spend a lot of time in the OR, which is great. Outside of that, there's always a little bit of variability about things that can come up. There's other training sessions that happen at night and things like that, but those are sort of more of a rare instance than the norm. I should probably also mention that we have a general surgery resident who rotates on our thoracic service at all time. We welcome medical students whenever 3rd or 4th years want to come into the fray. So some of your days devoted to teaching one way or another in that regard. We have a PA residency here, so we see PA residents floating through a lot, PA students, big academic place. It's sort of, you get that academic flavor that you would expect. So that's a part of our sort of daily life too. It's also, a lot of fun and creates a nice environment for people who are learning on some level or another.
Yeah, that's awesome. One of the things, as I've been interviewing different surgeons in different fields, one of the things that they've mentioned that as a positive for programs is that they're in the OR more or earlier on in the program. That's always a plus. And so I like hearing that you're in the OR a lot for your program. So that's a big plus. And not true for a lot of programs, so that's pretty cool. The next question is, where do you want to practice, or maybe not where, but how do you want to practice? Do you see yourself doing private or academic, and do you consider like being urban or rural, that kind of stuff?
Sure. So I think, for whatever reason, when I was a med student and even a junior resident, you felt like there were these like 2 big camps, right? There was like the academic world and there was the community world, and they existed, across a river from one another, and like you could kind of look over there, but you could never really be involved in either side. And coming through now, I'm in the middle of a job search right now. You realize that those lines are not nearly that stringent. Like obviously
Okay.
here at the University of Florida, we're on one end. We're a big, tertiary care center. We have a medical school, a nursing school, PA school, the undergrads, like the whole 9 yards. And we are heavily invested in the academic world. And obviously there are, complete what you call community programs that are staffed by either hospital employed or private practice physicians, and there are physician extenders that are helping out, but there's sort of not an educational component in the day-to-day life and whatnot. But a lot of the world exists in between. You have your sort of academically focused community centers, you have your more community focused academic centers, and there are plenty of people, as I'm sure, as an osteopathic student, I realize, I'm sure you guys probably realize too, there are a lot of places where there are med students and residents running around that don't necessarily have a big university name attached to each other. So there's a gamut of options, right, that occur on a spectrum. It's not like you sort of have to decide which side of the border you're going to live on. All that being said, for me personally, the things I really like about academics are sort of the environment, and then having learners, if you will, around, whether that's med students or residents or whatever. I think a lot of people involved in teaching don't get the satisfaction out of the teaching per se, but rather watching somebody you're working with progress, right? So if I have you on my service for a month and you're a third year medical student, it's your very first rotation, and on day one we're talking about how you hold the instruments, but by day 30 you're closing skin by yourself. That's really satisfying to the on my end of things, and that's probably what I personally like most about academics, is sort of the teaching stuff. And so there are a lot of places that you can do that aren't necessarily the big university center. I'm sort of this is personal opinion, I'm just sort of less enthralled with sort of research grind and grant writing and things like that. I'm really glad that there are people that's their thing, and certainly a ton around me here that are doing great stuff, but long term it probably won't be part of my career. So ideally I'd like to work at a place that's sort of similar to this, in that it's a bigger place. You got a good volume, you're doing complex cases, there are learners around, there are people that to not only for you to teach, but to ask you questions. And often than not, it's our students that identify the gaps in our knowledge rather than ourselves. But that, for me, that doesn't have to be sort of the big downtown university hospital. I personally am married. I have 2 small children, so being in a nice community with good schools and safe places are desirable. That's probably a very politically correct way to say that I'm not sort of the downtown guy that maybe I was at 17 or 18. So, there are a lot of options when you're choosing, whether you're choosing, within cardiac surgery or in general, when you get to sort of that end game. And for me, I think more of the kind of that academically focused community center, or an academic center that would allow me to focus more sort of on teaching as my academic contribution rather than something else, is more what I'm looking towards.
Yeah, we just figured out where we're going for third year, and I just found out the hospital that I'm going to, which is kind of like what you're talking about. It's a big hospital, giant hospital. There are a ton of residencies there and residents and stuff like that. Tons of medical students go there. But even though it's in downtown Detroit, it's still a community hospital. So kind of similar to what you're talking about, which I'm kind of excited about. So yeah, that's pretty cool. And you've covered a lot of this, so this might be a moot point, but any advice for people that are considering your specialty, whether it's trying to figure out if the specialty is right for them, or things that they can do to be a good applicant to CT surgery?
Sure. I mean, both of those things sort of start at the same place, which is getting some exposure. Seeing some cases, taking care of some patients, whatever you can do to kind of get some level of exposure to the field is really going to help. Either solidify your decision or help you figure out exactly kind of how things work on the ground level and what life is like as a practitioner and as a trainee and all that kind of stuff. So if you're considering the field, I think the biggest piece of advice that I could give you is you really sort of need to be your own advocate. I don't know about you guys, but for us, cardiac surgery or cardiac critical care was not sort of a part of the standard curriculum. So if you want those experiences, you have to go out and find them. and you have to set up rotations, or you kind of have to do a lot of the legwork yourself in order to get that exposure and that experience. And then off of that, find yourself a good mentor. Find somebody who you look up to, sort of not only as a surgeon, but as a physician and as a person that you can talk to and sort of bounce ideas off of and help guide you through the process. And for a long time I thought, well, like that's got to be like the president of whatever big society that I'm interested in. Which is great if you have it. I was fortunate enough that I sort of did, but that's a story for another day. But it can be an intern, it can be a resident, it can be a fellow med student, just somebody who either has some exposure or some knowledge who can guide you sort of through the process. And then in terms of your application and sort of how those things go, is that involvement in the specialty on some level is always desirable. Again, on sort of our side of the table, we realize that not a lot of medical students, not a lot of general surgery residents have a tremendous amount of exposure to the practice of cardiac or thoracic surgery. And you, by showing that you found it and you know what you're talking about and you know what you're getting into, that sort of goes a long way. And the easiest avenue, and the one that people most often take, is probably research. You find yourself a mentor who's got some projects going on, you get involved, you learn more about whatever the specific thing is that you're working on, you produce a paper, you show that you sort of are able to work through that process. Those are all, desirable things. I know a lot of people that's not their bag and they don't love doing research or writing case reports or whatever. But there's a lot of ways to get involved with our specialty and any specialty that don't necessarily involve writing papers if that's not what you're really passionate about. I'll give you the examples from our world. The Society for Thoracic Surgeons, which is one of our sort of larger organizations, has an advocacy arm that works, in DC a lot, advancing legislation and initiatives that support our patients and support our specialty. They have a variety of events throughout the year. They take volunteers a lot. You can definitely get involved at the med student level if you're interested. There are charitable outreaches within our field. STS has a variety of different scholarships and things for people who want to do charitable work or overseas work. There are things like you're doing right now, engaging with the specialty, on a more personal level, talking to people around in some sort of structured fashion. Whatever you can do to kind of show that you're actively engaged with the field and that your interest is at a deeper level than just sort of like, oh, I saw this once and I thought it was cool, or whatever the case.
I saw an episode of ER once and I thought, oh, that guy looked cool. Yeah.
Is gonna go a long way. And I think when people are evaluating applications, everybody assumes like, oh, like I have to do a ton of research, or I need X amount of publications or whatever. And that certainly doesn't hurt. And it especially doesn't hurt if you're going to a big research institution. But what it really is a surrogate for involvement, right? It shows us that for an extended period of time, you were engaged with the specialty, you were learning about a particular pathology, you were working through the system of developing an idea and writing a paper or whatever. But if it's going to be advocacy, or if it's going to be volunteerism or whatever it is, just sort of commit to it, get involved at a deeper level, and that can sort of show the same thing on your application. So I think that's very important. And then obviously it goes without saying that you should try to get good grades and you should try to do well on the boards. And I think it would be silly for anybody to say, yeah, don't worry about your boards, it'll be okay. Because I mean, that's clearly not the case. But I assume most people in your shoes are doing that anyway. And so some sort of engagement is going to be good. And then find yourself a good mentor. The STS also has a program that will link you up with someone who has checked a box and said, I am interested in mentoring. If you can't find anybody. So if you're at a place that just doesn't do a lot of heart surgery or a lot of lung surgery and you want to find a mentor, there are avenues through the STS's website where you can find yourself a mentor, either at the trainee or at the attending level. And then just sort of work through it. And more often than not, sort of things will fall together where they need to be.
Yeah. On the topic of boards, I'm actually hopefully doing another video series with some program directors, because boards are changing for us. Boards are going to go pass fail after my year. They're all going to be pass fail. So it's going to be a very different world. Anyway, that's a side topic, but very interesting development, I think. But that's great advice. Thank you for that. So next question is, obviously keeping HIPAA in mind, have you had like a favorite case or a favorite patient, or even if, if it's not a specific patient, is there like, I really love doing a mitral valve replacement or whatever it might be, that kind of thing?
Sure. I think, as I mentioned, sort of aortic surgery is my particular niche, and sort of what got me fired up in the field to begin with. And one of the things that separates out our specialty from sort of every other specialty is use of cardiopulmonary bypass, right? We use the bypass machine. We can stop people's hearts, all that sort of fun stuff, right? And when you are on the bypass machine, there's basically a big tube that's going to take all the blood away from your heart. It's going to go to the bypass machine. It's going to get oxygen, do all those other things. And there's another big tube that's going to bring it back. And we send it through the aorta everywhere it needs to go. But if you need to operate on the section of the aorta where the brachiocephalic or the head vessels come off, you have a problem, right? Because if you put the aortic cannula, or where the blood's coming out, past there, there's not going to be any blood flow to the brain. If you put it where you normally put it, you're going to be flooded with blood when you're trying to do the operation. So the way we address that problem is a technology called deep hypothermic circulatory arrest. So we put a patient on the heart-lung machine. We use the heart-lung machine to cool the blood that we're sending through their body, and we cool them all the way down to 18 degrees Celsius. And they have basically no brain function at that time, right? So you have silence on their EEG or on a BIS monitor or whatever you're using. They're 18 degrees Celsius. And then when it comes time to operate on that chunk of the aorta, we turn the pump off, we take the clamp off, and we start working. And when you're doing that, the pump is off, right? So there is no heart rate, there is no blood pressure, there is no blood flow, and there is no brain activity, hopefully. By all sort of standard definitions, that's death, right?
Yeah.
And so we do what we need to do on the arch, whatever the case may be, like the case we were talking about last night. We get everything hooked sort of back up. We hook it back up to the pump. We turn the pump back on. And, the vast majority of times, it's not that bad stuff doesn't happen, but the vast majority of times the next morning on rounds, I'm having a conversation with that person. And we're talking about, whatever, their grandkids or where they come from in Florida or whatever. And it, from the first time I witnessed that to now sort of doing it, the idea that you can take somebody to that extreme and then in such a short period just have a chat with them like nothing happened still blows my mind. I mean, just still blows my mind. And so that's really one of the things I like about aortic surgery is that sort of technology. And whenever I get to sort of participate in that, it still surprises me. It still excites me. And so that's probably my favorite aspect of it. There's a million other things that I really like doing and all that sort of stuff. But if I had to pick one, it would sort of be the utilization of circ arrest. It's pretty mind-blowing.
That is pretty mind-blowing. That's pretty cool. That's I'm gonna have to like see if I can find one of those procedures on YouTube and spend my evening watching a video of that, because it sounds really I've never heard of that, and it sounds really awesome. I'm especially pretty cool that the next day can have a conversation with them about where they're from or their grandkids or whatever.
Yeah, I mean it's pretty wild.
Yeah, that's really awesome. Cool. So now I have the last question, which is really not a question, but really just a free time for you to bring up anything. And you've already told us a ton of really useful and really interesting stuff. So if you don't have anything here, it's totally okay. But at this point, sometimes people talk about research or boards, which you've already talked about both of those things. So if you don't have anything, that's fine. But if you have any general comments about your field or about matching in general, whatever, this is your time. You can talk about whatever you want to talk.
Sure. I mean, I think one, I would say that, cardiovascular thoracic surgery is a phenomenal field. This is a 100% biased opinion, but, we get to treat some pretty sick patients. We get to do some really cool procedures. We get to be involved in some life-altering and sometimes more often than not life-saving operations. You use a lot of technology. You're sort of at the extreme end of sort of the specialties, if you will, if you want to call it that. And it's a long haul, right? I mean, you look at the length of the training, it's not short by any means, but it certainly provides you with a really fulfilling and a really enjoyable life. I think if you have any interest in the field whatsoever, I would encourage everybody to get involved at some level. Find a mentor, email me, whatever you want to do, and get some exposure and see what you think. I think on top of that, we talked about some of the things that we think are important for people who are applying. There are now multiple avenues to board certification in the US. There are integrated I-6 programs, there are traditional programs, there are 4+3 programs that you can do. So there's a lot of training pathways. Educate yourself about them, figure out what might work best for you. Find a good mentor, bounce that idea off of him or her, and see what you can. And I think lastly, you guys are at an osteopathic school, and obviously I'm a LECOM alum, and I think there is a perception kind of in the world that maybe certain specialties or avenues are not open to us as a whole, or maybe to people who don't have sort of that really high-end medical school background. And I don't think that that's true. I think that if you sort of are willing to put in the work, and if you're willing to engage with the specialty and with good mentors, that anything is still open to you, even if it's not heart surgery, if it's plastics or peds or whatever, any other competitive specialties. You shouldn't count yourself out by any means. The further along I get, the more I realize that the education I got at LECOM was really good. It was challenging, it was practical, and it prepared me for a good career. And I think that that's probably something that is true across most DO schools out there. The way they accredited residencies is changing, the boards are changing, so I'm sure this is a dynamic process that'll change a lot. But you certainly, not a lot of us running around the cardiac surgery world, but there are enough. There are enough to find good mentors, and there certainly are enough that it's not only possible, but it's an option. It's not something that's just a Hail Mary. So I don't know if anybody who watches the video or who's sitting in your seat sort of shares those anxieties. I know that for myself, it was certainly an issue when I was coming into general surgery. And then when I applied for a fellowship, I had those anxieties myself. But I think collectively we all can rest assured that we got a good education, you're getting good training, and that if you apply it, whatever you want to do is available to you. And again, in my biased opinion, if you want to do the right thing, you can be a heart surgeon. And if you don't, then that choice is up to you.
Yeah, that's really great advice. And I really think that a lot of us students, including myself, need to hear that we can achieve whatever we want to achieve, even if it seems like there are fewer DOs in certain fields. So that's really great. And in general, this has been a great interview. I really appreciate all of your insights, and thank you so much for spending some of your time. I know you're a busy guy, so thank you so much.
Yeah, not a problem. It was my pleasure.